Good morning. We're just waiting for people to join. So if we give it a couple of minutes, just while everyone who's in the lobby gets allowed in, and we'll get started in a couple of minutes.
Thanks, Sarah.
Just going to give it one more minute, and then we'll kick off if that's okay. Okay, so I think we better get going. People might join late, but hopefully they will catch up. So just a couple of housekeeping points before we get going, and we will introduce ourselves in a moment. But from a practical point of view, the meeting is being recorded, so there will be a recording that can be accessed afterwards. And if you've got any questions, we will have time at the end for a Q&A, but if I could ask you to pop your questions into the chat, and then they will be picked up, and we will deal with those at the end of the session. And I think that's it from a housekeeping point of view. Cameras are off, but we will, obviously you can see the speakers, and hopefully that will be highlighted as we go along. So a warm welcome to everybody. It's good to see people here. This is the third and final of the Acumentice three-part webinar series on community health waiting lists and waiting times. In the first one, for those who attended that, there was a focus on the importance of mental health waiting time measurements and what this means actually for the service user experience. In the second session, the panel discussed how to manage mental health waiting lists effectively and why it's so important, why it's so crucial. So now we're coming on to number 3, the final one in the series, and this is looking at how improving performance can help actually bring those waiting lists down, which is ultimately what we're all hoping to see happen. So in terms of who you've got in front of you today as your presenters, I'm chairing. My name's Sarah Betterley. I chair HPFT, Hertfordshire Partnership University Foundation Trust, which is obviously a mental health and learning disability trust. And we've also got some great speakers with us who I'm going to allow them to introduce themselves, so you know who you're hearing from. So first of all, let me hand over to Karina.
Thanks, Sarah. Hello, everyone. My name's Karina Malhotra. I'm the Managing Director at Acumentice. And effectively, we are an NHS-focused improvement consultancy. All of us are ex-NHS, and we've come together to deliver various types of improvement projects back to the NHS. However, one of the areas of focus for us across both physical health and mental health sectors has been and continues to be improving waiting times, whether that's from a operational, data or process perspective. So I'm looking forward to talking to you more today about some of the tools that we use to achieve that improvement. Thank you.
Thanks, Karina. And our second speaker is Kartik. Kartik, do you want to introduce yourself?
Thanks, Sarah. Good afternoon, everyone. I'm Kartik Chinnasamy, and I work as a Director of Performance at Norfolk and Suffolk NHS Trust, which is the mental health trust. I've been with the NHS for over 18 years now and worked in both acute and mental health trusts, mainly in London, but also in other regions for the last few years. My background was initially in operations for a number of years, but did some transformation and cost improvement roles for a few years before I moved on to performance and business intelligence roles. I have specific interest in improving waiting times for mental health waits. Great to meet you all today, and thanks, Corinne and the team, for inviting me here.
Brilliant. Okay, so we're looking forward to the session. It promises to be a really interesting one. And without any further delay, I'm going to hand over to Karina. Thanks, Karina.
Thank you, Sarah. Okay, so as Sarah's kind of introduced the topic, as you heard, this is all about how do we improve mental health waiting lists effectively. but I will just sort of very briefly remind us quickly about the first two webinars and what we tried to cover, or certainly the key points from it. So as Sarah already alluded to, the first webinar we held talked about the importance of accurate waiting time measurement in mental health. We often hear about waiting times being spoken about quite a lot when it comes to physical health and acute trusts and referral to treatment pathways, as many of you will be aware, but perhaps not enough around mental health. And so for us, this entire webinar series is about sort of creating that that space for this particular topic, which we don't feel it gets. And that's why we talked a lot about the experience from the service users, and we had our GP colleagues attend the last webinar to talk about that. But we also talked about how there is very evident variation in waiting times across mental health organizations. And for that reason, we recognize that there is a data quality problem there as well. And in order to give mental health the same attention and same parity of esteem, we must start talking about it more as a starter for 10. And hence we are here doing this webinar series. And when you receive this slide pack, you'll see there's a link to watch the first webinar on this slide as well, so should you wish to do so. Very briefly again, so the session 2 then built up above the sort of previous webinar, which talked about why is it important, to moving on to, okay, well, we've recognized it's important, but how do we actually manage that in a mental health setting? So my colleague, Michael Watson, along with some excellent speakers on the panel, we had Sean Duggan and Joe Hillier from Sussex Partnership Trust, talked about the importance of defining very clear waiting times milestones. How do you optimize your data recording? So now we're starting to get a little bit technical, but how do you actually do this thing? How do you build something called a patient tracking list, which many from physical health will know really well, but how do we do that in a mental health setting effectively, considering that the pathways are slightly different and perhaps not as linear as in physical health. But more importantly, once you've done all of that, how do you build the right kind of governance to sit on top of it? So indeed, you utilize those tools really effectively to manage your waiting list. So that's kind of a quick jump through the last two webinars and why it nicely sort of brings us to the topic of today, which is obviously going beyond management of the waiting list. But I'll hand over to Kartik to set the scene for us today.
Thanks, Karina. I mean, as the slide shows, I mean, we just kind of realize there's a lot more scrutiny and importance given to waiting lists in mental health, which wasn't there before to some extent. So the 104-week report is going to be published very soon. And I mean, there's general perception that, I mean, the waits for mental health is quite long. I mean, I think both management and improvement are equally important. And I thought it would be helpful to clarify the difference between management and improvement. I mean, in my view, the management is around someone constantly monitoring the waiting list, looking at capacity, offering appointments in the right order, looking at demand, etc., which we'll cover in more detail later on. But for me, the improvement is about things that happen behind the scenes. For example, looking at whether the patients added to the waiting list are clinically appropriate and directed towards a more suitable service, proactively monitoring changes in referral patterns and taking actions before the backlog starts to build up. The efficiency of whole pathway of the patient is also important, which means whether the waiting times in one part of the pathway is creating a bottleneck and addressing them. We will be covering that again in more detail in the last section of the webinar. Effective partnership between primary and secondary care with appropriate protocols and documentation in place for referrals and discharges. For example, some GPs are not comfortable with filling in a referral form with the right details when they, when the patient gets referred. They would like to follow their own processes and protocols that can lead to inappropriate referrals and delays in getting more information about the patients while they're waiting. So all these things play a considerable part in improving the waiting list. And yes, I completely agree, it's important to focus on both management and improvement. I hope that helps, but I'll pass back now to Karina to take it forward.
Sure. Thank you, Kartik. And it's such a good point. And that's the point, I guess, around our theories, which is we need to understand the problem then we need to learn how to manage the problem, as you rightly say, and then we need to move into this improvement sort of methodologies, which is what we're going to focus on in today's webinar, as we've mentioned. And just, I guess, the only other sort of introduction piece for me is there are many methods and tools out there developed by different people, including sort of localized tools, etc. What we are going to use today's webinar to do is show you 3 key tools, really practical tools that you can use to not just manage, but also build on that management and actually improve those pathways for service users when looking at the waiting time challenge. So we'll cover 3 today, and I'm going to kick off with the very first one. Between Kartik and I, we'll talk through the theoretical element, the practical element, and indeed specific experience from the front line of using these types of tools and what you can gain from them in terms of insight, but also actual impact on the front line. So I'll kick off with something that many of you will hopefully have heard about, which is demand and capacity analysis. So we talk about this a lot when we work in physical health settings, not as much, certainly from our experience, when we work in mental health settings. And it is a tool which, you know, for obvious reasons, is quite key in service planning. So I'm just going to talk through some practicalities of how the tool works, and then I'll move on to show actual tools that are relevant and useful to be used in the mental health setting. So what kind of things do we actually input into a tool to get this kind of demand and capacity analysis? And mind you, what we're trying to do is really understand what is coming through the door and have we got enough capacity to manage all of that. But it's a little bit more than that. So let me just go through that. So very briefly, you know, there are 2 key inputs, which is what is your demand? So what is the demand for those services or specific service that you are conducting this modeling for? And how much capacity do you actually have in that space? Now, this might be connected to your job plans, how you've constructed clinics on EPRs, and so on and so forth. But there's a little bit of flavor that we put on top of it, which I think is quite essential. So these are sort of parameters or variables which must be applied on top of that demand and capacity to get you to the key outputs, which I'll show in a moment. And that's things like, how about those service users who entered your waiting list through that demand route, but actually were removed before they received their intervention and they did not need to go through that entire as well. And of course, any kind of DNAs and cancellation numbers, etc. There are several other parameters, but these are the types of things that you would look at to overlay on top of your demand to get to what are the 2 key outputs of most demand and capacity modeling that's out there. And of course, you can make this really complex or simplistic, but the 2 most important things that come out of demand capacity analysis are very simply, what is that gap? What is the gap between your demand versus your capacity, and what would it take to fill that? So that's that required capacity element. But the second one is sustainable waitlist size, and I just want to take a moment to explain what that means. So essentially, sustainable waiting list size is the size of your list that your service should aim to treat in a timely manner in order to be able to manage the steady incoming of that demand. So based on your demand, your capacity, all of those parameters, what can you genuinely manage in a waiting list size without the waiting times tipping over too much into what we might describe as long waiting times? And therefore, what this modeling will also provide is the gap between your sustainable waitlist size and your current waiting list size. So those are kind of the things it does. And I'll just sort of show you a quick example. Here's a demand and capacity model that was developed by NHS England. It's called the core model. This is really helpful when you are looking at individual stages, and individual stages in mental health might be referral to assessment to first line intervention, and so on and so forth. The reason I'm sort of talking about a slightly simplistic core model such as that, which is dependent on stage level modeling, is because it is easy to use. The kind of information you need to input into it is is easy to gather in most scenarios, and it's a bit forgiving when there are data quality challenges, which we all recognize in many organizations we do have. And this is just sort of showing you a visual of how the demand and capacity inputs look once you've entered it into the model. The model itself maps it out for you exactly as you see on your screen. And then what do the outputs look like? So after you've done the modeling in the core model, if you look on the left-hand side of your screen, it gives you that gap within required versus available capacity. And in this example, it's saying that really where you are is at the cross, but where you need to be is at the bar. So that's your gap. Similarly, on the right-hand side, the waiting list position shows you that actually your current waiting list size is sat at about just over 2,000 over here in this example, but where you need to be and to get to that sustainable waitlist size is this green bar. And what the model allows you to do is say, I would like to clear this backlog, and this gap indeed is what we refer to as the backlog. In 12 weeks, you might choose 15 weeks, so on and so forth. And it then tells you what is that gap and how long it will take, and indeed what capacity you need, both to meet your steady demand, but also to clear the backlog. And that's why we really like this core model, which we'll link to, so you'll have an easy access to getting to there. And NHS England have provided lots of interesting user guidance around it. I do want to take a moment to talk about something which is called a higher complexity model. Again, it's available on the NHS England website. And the reason I want to talk about this one is because it allows for the caseload style of management in a mental health setting. It is ideal as it helps map services where patients may return or service users may return for follow-up appointments or follow-up interventions and so on and so forth. The reason I've not started with this, because you might say, well, that's ideal for mental health, is because as it says on the tin, it is a complex model, and it requires a lot more complex and indeed accurate data sets. And we recognize that can be challenging for that reason. Most importantly, for example, it needs really accurate activity data, and that is a challenge to achieve. So if you're just starting out, it is always advisable you start with something straightforward like the core model and build up to the higher complexity model as you become used to it. And on screen, I'm just showing some sort of visuals of what it might look like. So the top graph shows you the caseload demand information, including some predictions. So here's some demand information. And then at the bottom, of course, is the capacity, where it shows you the capacity available versus the capacity required. And then last but not least, it also gives you sort of various other bits of information, but it's very similar to the outputs that I've already shown you in core model. However, this is now mapping out the entire pathway. If you remember, the core model was all about stages, whereas this one is indeed about a complex pathway with several follow-ups and interventions built into it. So again, links available, so please do check these out and use them as you will. But we find that certainly as we start this kind of work in mental health, starting with the core model gives us insight into what needs to be addressed from a data quality perspective in order to make the higher complexity model more useful. That's it from me. I'll hand over to Kartik to talk us through some impact on the front line that he's achieved by doing this work.
Thanks, Karina. I think that was quite extensively covered in terms of the principles applied and how we wanted to create a model. And we kind of applied some similar principles, but we developed our own in-house demand and capacity model because the NHS England model was evolving when we started to develop our model, and it wasn't as mature as it is now. So in our model, we went with those basic principles and variables that we needed to apply, but also supplemented with a couple of other things, which is not a statistical model. For example, we factored in, we tried to understand how many assessment and treatment appointments a patient would need, depending upon their medical condition, before they can be discharged. That's something that Karina covered earlier around complexity. We also did an audit called a diary study in a couple of services where around 30 staff manually noted down what tasks they perform on any given busy day for them, to understand how much time, that's clinically spent, and are there any other activities that they perform that can be actually delegated to any other staff. So the study showed some interesting findings. One of the study indicated that some staff spend less than 20% of their time as their clinical contact time, as the chart shows. So the model helped us understand a few things, whether we have sufficient capacity or not. If you could move to the next slide, please, Corinne. Thanks. So it helps us understand whether we have sufficient capacity or not. And are there any opportunities to reduce some of the non-clinical activities by freeing up clinical time? Strengthening our administrative function to take on some non-clinical activities done by clinical staff. To give a couple of specific examples, how the model impacted on the front line. It identified an investment requirement of around 2 million for a specific service, which they managed to secure, which helped improve their waiting times by 35% in a span of 6 months. But a similar exercise conducted with another service, which requested for around 900,000 of additional investment in resources, found that they do not need any additional investment by implementing some of the points discussed earlier around freeing up clinical time, strengthening administrative function, etc. So there are some really tangible benefits and improvement there. And it identified the gaps that Karina earlier talked about. So yeah, these are the real benefits that we have actually benefited from. Hope that was helpful, and I'll pass back now to Sarah.
Thank you. So really interesting sort of setup and start to that, and it highlights. I'm just thinking for me. A couple of things. There's certainly the complexity issue, and from what you're saying, there's a real sense of being able to model and understand our demand and capacity, but taking into account the fact that what we do as mental health trusts in particular is incredibly complex. So the range of services and the different range of need, and therefore what we count in our waiting lists is actually a multiple set of lists for the different services that people need, and actually the target wait time for those services will vary also. So there's some challenge, isn't there, as to how we use the model most effectively to apply our efforts in a way that optimizes perhaps the right experience for our service users, and actually helps us make the best use of the limited resource. Because you're right. What you're saying, Karina, in terms of identifying our demand levels, understanding the gap, and then having this ideal understanding of what our capacity requirements are. The obvious answer to that would be, well, just give us a bit more money and we'll recruit more people, and then we'll be able to just deal with it all, which clearly in the current environment we know is absolutely not an option for us. So being able to be smarter and be supported to make better use of the resource we do have, so that we can try and squeeze that gap through performance, efficiencies, improvement, and all of those things that you're alluding to, feels like it's even more important than ever to give us a chance to get that better service. I'm just wondering how much within the modelling that you're describing here is there scope to handle the nuances of different target levels and different capacity issues between different services even within community mental health, because there's a range, isn't there?
No, absolutely, and that's such a good point, Sarah. So and that's why I've kind of started by giving two potential models one can use. But what we do often is we might start with the core model, which as I described is kind of stage led, because even stages might have different milestones, right, and targets and things like that. You must see somebody within 48 hours in a certain service, and so on and so forth. And that's why it's really helpful to almost build your understanding of your services demand and capacity challenges, if there are those, or indeed just the profile of it, by using these different models to model each section. The higher complexity one can do that, but as I sort of highlighted, to sort of bring all of that together, but it does require, well, firstly, it is very complex, and it takes time to do that. But you can achieve some of that intelligence by using that core model, and the core model will allow for that kind of nuances quite easily, because you are talking about, well, I'm mapping out my referral to assessment only in this section, and that will get you almost sort of targeted bottleneck understanding as well. And what we find is when we do it at that almost sort of stage level, it's almost helpful to do that at the beginning, even if you had all the lovely data you need for the complexity model, because it allows for that real targeted introspection, if you will, at both operational and clinical level, to think about, is that truly the demand? What are the other parameters I must consider? And what is the operational intelligence I must apply to this model? Because, we can do a very sort of straightforward add, subtract kind of model, but these models have been built to try and understand some of those parameters that do change your demand, that do change your capacity, your leave, your job plans, all of those kind of things come into play. And by working at a stage level, it just allows you to really hone in and target that specific element of the pathway, get that bit right before you move on to the next, and so on and so forth. And doing that sort of foundational work allows you to then build up to something more complex, like the higher complexity model. And indeed, or do a very bespoke version like Kartik's described, which might be more suited for the aims of the organization. But it is really helpful to go at a stage by stage level, is based on my experience, certainly. And it unveils certain challenges that you weren't expecting. It's only when you start seeing the numbers play out, then you're like, oh, yes, I understand why this is happening. It's because of this. But it doesn't always sort of, there are so many things going on in sort of leaders' minds in NHS organizations. Always, it's not always sort of upfront, and doing this type of modeling sometimes reveals things that you didn't realize were happening even.
And some of it will be about sort of prioritization, but I'm hoping that the modeling itself helps an organization to understand those things where we can influence it ourselves, because obviously just pure demand is not directly within our control. Of course, there are things we can do in terms of earlier intervention and prevention to try and impact the demand itself, but some of that is completely out with our control. So it's helping identify those things that if we apply our efforts and the investments in the way that Kartik has described, we can have the maximum impact on trying to close that gap. And it's about closing the gap rather than simply stemming demand, which you can't directly control.
Precisely, and it's about trying to identify those bottlenecks, exactly as, and I'll invite Kartik in on his experience on that as well. But one of the things we'll talk about sort of later on today as well is something, another tool in our sort of toolkit around sort of analysing when things don't go right and patients or service users end up waiting much longer than we wanted them to. How can we analyse that information to understand what is that bottleneck? And that's one way of getting at it. Obviously, some of the diary work and detailed analysis Kartik's described is another way of looking at it. So these are all sort of ways to do that. But you're absolutely right. It is about sort of really honing in on what is within our control, and we can actually sort of make a difference to. But equally, what is not within our control is important to understand, because when you are doing business cases or talking to ICS colleagues or other regulators, you've got the narrative to be able to say, this is something that is not within our control and we need your help or the system's help in resolving it. And sometimes just that information and that data is the power one needs to make that change. But yeah, Kartik, sorry, go for it.
I think you kind of covered it very comprehensively, Karina. I think demand and capacity is just one part of the puzzle. Sarah, you already kind of touched on that. So I think looking at the population health level information to understand what can be done from a primary care perspective and what can be done from a community perspective to provide that early intervention and prevent the early identification of demand that can be reduced, because I think if and especially around different ethnic groups and inequalities, understanding inequalities, and identifying if any particular cohort of patients are not actually accessing our care and intervening early and reaching out to them, I think will also create an impact on the demand coming through the door. That's what I wanted to add.
It absolutely will, although of course, as we've found from my trust, reaching out into those harder to reach communities is a very positive thing to do, but it can swell your demand as well. So you need to know what you're letting yourself in for and try and anticipate it. And I guess this modelling
Precisely
helps with that. So shall we move on to the next section? You can talk us through the next tools and the trajectories and breach analysis that you've been working on. That would be helpful to hear.
Yeah, thanks, Sarah.
Thank you.
Okay, so we've talked about demand capacity, and now I was keen to bring to the table setting and tracking trajectories. You'll remember from one of our earlier slides, and Kartik mentioned how NHS England is going to be asking all systems to produce trajectories of improvement on any patients or service users who are waiting longer than 104 weeks, and hopefully you don't have those in your organizations, but should you have them, obviously there is an expectation from regulatory organizations to be able to see that improvement trajectory and what that would look like. So we were just keen to sort of talk through how to create a meaningful trajectory. And quite frankly, it kind of builds on the work that we've just talked about around demand capacity. So all of those inputs and outputs that come out of it are really the variables one needs to sort of craft a sensible trajectory. And what I've put on screen is basically it, which is the things that you want to consider when you're creating a trajectory is not simply, I'm here, I need to get there, and I'm going to draw a straight line between those 2 points. But it's really about being realistic, and some of it might sound a bit sort of simplistic and common sense like, but often in our experience, that is something we need to talk about more explicitly when we're creating these trajectories to make sure they're meaningful. So some of the things we always go through are working in collaboration with the people on the front line, whether that's clinicians and sort of managers and other leaders, because the operational and clinical intelligence around when is my demand going to swell, when is my demand not going to swell. We know from our understanding the CYP services get a real peak in September and October, whereas adults in mental health often around or after Christmas. So when you know that those kinds of things are coming, can you realistically say that even if I keep all my capacity the same, I won't see a little swell in my trajectory? So it is about sort of taking that operational intelligence, any additional capacity that we're putting in place. So demand and capacity has been done, analysis has been done. It's told us we need 50 additional appointments per week in order to meet our steady state, but also reduce our backlog. So we need to map that into the trajectory. And of course, set a time scale of expectation, and that will help us get to something like a meaningful trajectory. And I'll show some examples because a picture always is better than words. So here is a straight line trajectory, as I described. There is a starting point of, say, you have 80, perhaps breaches, etc., and you want to get down to 0 in a matter of sort of 6-7 months. And here's a straight line trajectory, and these are trajectories I've seen being created, which are purely numbers based. So they don't take into account any of those variables that I was just referencing. So yes, on the graph, it's absolutely hitting the target, whether that's a target set by NHS England or commissioners or indeed your own organization. But is it really going to be met? Probably not, because there has been no intelligence applied to this. This is a very straight line trajectory, and we highly advise against that. So what we need is, going back to the word, a meaningful trajectory. So here's an example of exactly the same starting and end point. So we're still starting at circa 80 odd breaches who are going to be cleared in the same amount of time, but you can see that it's sort of swelling up and then comes down again and swelling up and coming down again. And this is based on operational intelligence. So we're saying that actually we know that the demand is going to go up in certain months, and so our current capacity won't be able to handle it. But then later on in this timeline, we will add additional capacity, and that will lead to a faster sort of reduction in the months that we know that the demand is perhaps not going to swell as much, and we will then hit the target. in a more realistic way. And not only, I guess the last point to make on this is the straight line version meaningless. It won't stand up to against any challenge coming from colleagues from NHS England or indeed ICBs for that matter, because they'll recognize that it is a straight line and it doesn't have that kind of operational intelligence baked into it to keep it meaningful. So that's how we advise. Of course, what you do it on, whether you do it in Excel on a graph, that's not a difficult task. It's what feeds it that's the most important element of putting together a trajectory. And the last point from me on this topic is about, you've got your trajectory now. It's meaningful. It's got all these variables, but it's over a sort of a long timeline, and you must monitor and track it. It's great to set targets, but if you're not monitoring them, you don't take the time to make the adjustments that you need. And so I'm just showing on screen one of the trajectories that we've helped an organization pull together. And the sort of the blue and the yellow sections are actuals, whereas the dotted line in pink is the trajectory, and you can see we're tracking it on a regular basis. One of the additional information we've added into this trajectory, which we feel really helped the organization, was, well, how many are dated and undated? And you can see if you go to sort of the early dates within this graph, there is a large number of patients who are dated, and they are obviously falling off. But the number of undated patients continues to be high, and you can see they have stopped hitting the trajectory. And this is when people who are accountable should be sort of stepping in and saying, well, why aren't we dating these patients or these service users to make sure that we are getting closer to the trajectory? And of course, there's several reports that can sit underneath this type of analysis, but this is on a page telling you why you're not meeting your trajectory and by how much at the same time. So it's just an example of a monitoring mechanism, which obviously we highly recommend follows the construction of any trajectory. I'll hand over to Kartik to talk about his experience on this front as well.
Thanks, Karina. I mean, good points there on straight line trajectories and how it does not instill the confidence that it should. So I would just start with how the trajectories are set at NSFT, which is realistic and meaningful. We took the baseline waiting list and used the demand capacity tool to do some scenario modeling. The output of the tool is in the charts. So as we can see on the left chart, it is not a trajectory. It just shows that if we don't do anything, how much the waiting list will grow in the next couple of years. And the right chart shows what will happen if we implement some interventions. For example, S1 stands for scenario 1, and it's adding some additional capacity through resource investments. Scenario 2 could be how much additional capacity can be created by freeing up the clinical time, and what is the impact of that. The additional freeing up the capacity, which we discussed in the last section. So this was done for both 4 and 18 weeks in the same chart, and it shows by which point or how many weeks or months it will take to be on top of each of those weights. So this is how the trajectories are set. It's quite scientific and meaningful, and not made by any general assumptions or a straight line trajectory. Hope that was helpful, and I'll pass back now on to Sarah.
It's me.
Oh, sorry, Karina.
Yeah, that's okay, Kartik. Thank you. That's really helpful. And I guess it's just trying to show that, trajectory setting is, as you say, reasonably scientific, and the numbers play a role in helping guide you, but those operational principles are just so key. And of course, I really like scenario modeling, and that helps decision making in many ways. So we'll move on to our last tool of today, and that's called breach analysis. And I will talk you through it first. So what is a breach? For us, a breach is when somebody is not seen within a defined standard waiting time. So in physical health setting, that might be 18 weeks. You're not being seen within 18 weeks. Cancer has different targets. We were talking earlier about how mental health has different standards for different services and teams. We know community mental health waiting times will be measured against a 4-week standard very soon, and so on and so forth. So we've just, I don't plan to talk through the detail of this slide, but it's really important to understand what is a breach, and a breach can mean whatever threshold has been set in terms of waiting times in your organization or through regulatory bodies. And what is breach analysis is all about analyzing anybody who doesn't meet that threshold when they have received that first intervention or treatment or assessment, whichever stage you're looking at. Why was that? And that's why that's what breach analysis is all about. Why do we do it? Essentially to understand the themes that are coming through. Why are these particular individual pathways not meeting that threshold, and try to understand if there are specific bottlenecks. And that's what it helps to improve. Once you've done that analysis, it gives you insight into what is causing those delays or what is causing those challenges. Demand and capacity mismatch is just one of those reasons. There are so many different reasons that contribute to delays within pathways, and this is kind of our bread and butter. So we've seen multiple different issues, and they don't always fall neatly within we just don't have enough capacity. There are lots of other improvements that one can make, and that's why identifying those problems so that you can target them is really important. So when talking about breach analysis, again, going back to how I described demand capacity, there's a level 1, and indeed there are 2 other levels of analysis tools that I'm going to talk you through today. So bear with me. But I think the important point to remember is that the more you do it, the more intuitive it becomes, and it becomes more clear, and it becomes faster as well. So the first level for me, if this has never been done within the organization, is essentially capture and track those particular pathways, and I'm talking individual service user level pathways that have not met that waiting time standard or have breached. It's important then to map out each and every event that happened within. So it is manual and it is time consuming, but the rewards at the end of it are just as useful if you can eliminate this problem. But once you've identified those individual pathways that you are going to analyze, then you start mapping out each and every key event within their pathway, put down the number of days each of those events takes, and then understand if it was more than what you expected it to, if it took, I don't know, 3 weeks to triage something when it should take 3 days, what was the reason for it? And can you identify, therefore, what are the kinds of themes that are coming out of it? So this is a really sort of manual starter for 10, if you've never done it before, just to get a sense of what are the themes that are coming out. I'll just show an example. It's as simple as creating a proforma like this. There are plenty out there. They're used in cancer very often. Some of you might have seen them in that type of a setting. This is an example from there as well. And it is about just identifying individual breaches. Why did they breach? How long did each part of that or each stage of that pathway take? And can we identify the kind of themes that are coming out? The more often you do it, the clearer that thematic list will become, and it allows you to really understand, well, actually, every month we're having 20 breaches and 10 of them are because of X reason, and therefore that is the biggest contributor, and we must try and address that. So the level 2, which I'll go on to, is really looking at those aggregate numbers. So you've started doing sort of level 1 of individually managing these breaches or understanding what's causing those delays. Then you want to aggregate those numbers and try and work out what is happening on a month-by-month basis and build time series to clearly identify those trends and particular themes. And here's an example of a tool a colleague built in a mental health service actually. And what it's trying to do is, and obviously it's got some calculations built within it. It's trying to separate the reasons because they already know these are the most important themes. It's trying to separate the reasons between service problems and patient-led reasons of I'm unavailable, etc. And what it allows you to do is that once you're entering that information on a monthly basis, just at a number level, of course, you'll still need the detail that I described previously in order to get here. If you're recording this on a month-by-month basis, you will easily be able to see which theme is coming out on top on an aggregate level. On a month-by-month basis, are certain months particularly bad for a patient choice, summer and so on and so forth. And this will allow you to really try to pin down which particular theme is coming out on top in terms of causing those bottlenecks. This, I think, is a good framework to begin with, certainly, because it starts to sort of really get into what are those key themes. And obviously, you can make it as granular as you want. I will take a very short moment to just pick up on the last one, which I won't talk about too much in detail, but something called a pathway analyzer tool, again, available online, and we'll make sure we put the link to it. Now, this starts to go into intricate detail at a milestone or a stage level. And what it tries to do, it exposes individual stages and the themes within those individual stages. Whereas the previous two methods I've talked about are in the entire pathway, what was the theme that caused the biggest delay? This is starting to go at a stage by stage basis, and it helps you isolate those steps in a pathway, and that allows for even more focused interventions to be built. And if I just zoom into what these are just a couple of outputs, again, slightly more complex model. It requires a lot of input and data being entered into it. But as you can see, it's trying to take individual pathways in the top element and showing you how many days each of those took. It's RAG rating them against targets you might have set within it. So first appointment, anybody over 7 days is in red. So basically everybody is in red in that example. And then it allows you to go into also trying to work out the ones that, so what this tool also allows is you can analyze your breaches against non-breaches and try and work out why did those service users who met the waiting times threshold, why did they meet them and what was the difference between them? So this tool really is quite a detailed and analytical tool, but it gives you that very granular detail as well. So I'll move on and hand over to Kartik.
Thanks, Karina. That was really helpful. I mean, and those templates were excellent. And I think, we haven't gone to the stage 3 yet, but I can understand the value of actually moving towards stage 3. So, almost all of us will be aware of PTL, which is patient tracking list in acute terms. And we have something similar at NSFT, which is called a SUTL, that stands for Service User Tracking List, very simply. So the SUTL gets presented in our trust-wide access group meetings. Each care group will present the reasons for all individual breaches. It has all the service users waiting split by number of weeks, and each service is reviewed working backwards from the longest wait, and will have actions and recovery plans in place. There is extensive involvement from our exec team, especially from our chief operating officer, which helps to have the level of rigor it needs. There are a number of benefits with this process, and I'll list a few. One, it helps us understand whether the wait is attributable to the trust, which again, you kind of covered, Karina, earlier. For example, if any patient is continually unable to make the offered appointment, then that wait is not attributable to the trust. And mental health do not have a stringent DNA policy like acutes have, where they can be discharged if they haven't turned up for 2 or more appointments. And it is not always possible with mental health, because of the risk factors it involved. So they are always kept on the caseload. They don't get discharged. They do risk mitigation plans, but they hardly get discharged. It also improves data quality and our activity counts. For example, if the appointments are not outcome, then it does not stop the waiting time clock. So the breach analysis investigation will help us identify those unoutcomed appointments and actioning them and stopping the clock. So I don't want to go into too much detail into it, but this improves not only data quality, but also waiting time performance and activity counts. And it also helps us understand whether the performance is a real performance or whether it's just data quality and some cleansing that needs to be done to really understand the real performance. Last but not the least, harm reviews are conducted on any long waiting patients to assess the risk and develop any mitigation plans, because I think the trust takes quality and safety very seriously. So those are the benefits, and I'll now pass back on to Sarah, and I hope I got this right, Karina, this time.
Thank you. Really helpful for both of you. I don't want to hog things. Let me just invite Lucy to let us know if there's been any questions posted, so we can try and get through as many of those as we can from those who've been putting things into the Q&A. So Lucy, is there anything to bring up at this point?
Yeah, hi, thanks, Sarah. Yeah, thanks both to Karina and Karthik as well for all those insights. We do have a couple of questions that have come through. It was quite a big question, I guess, but why not? Let's go for it. If there is one improvement that providers could make over anything else, what would it be? I don't know who wants to take that one.
Shall I attempt? So let me start with a disclaimer that there is no silver bullet. Improvement is small things being done in lots of different aspects of the pathway. There might be a capacity thing, there might be how you do the tracking element, there might be various other elements that need to come together in order for overall improvement to truly take place. Having said that disclaimer, for me, if you sort of look at all the tools we've talked about today, some of the extra stuff that Karthik's also talked about from his experiences, all of it comes on the foundation of getting good data being recorded and captured on your systems. And for us, most improvement projects that we end up conducting end up starting at that point. So we must sort of get almost that sort of data stage right. And of course, most trusts, whether you're physical health or mental health, have data quality challenges. In complex organizations like this, that is not uncommon. But taking the sort of improvement work and data quality together allows us to fix both at the same time, and that's what we find has really helped us make the biggest improvements in the shortest amount of time, where we are recognizing the data problems, but we're still building perhaps a waiting list or a dashboard, because those kinds of tools then highlight the gaps that already exist within your data. So the foundation for a lot of improvement work is evidence and is data, and is identifying those targeted places that you can start the improvement. And of course, every organization differs. So, when you conduct a breach analysis in X organization versus a Y organization, you will find very different contributing factors. But how are you conducting the breach analysis? By looking at your data. So for me, that is the foundation of a lot of improvement interventions one can make.
Can I just ask on that? Because one of the things you've just talked about in the previous tool was the sort of manual element of capturing all of that data so you can do the analysis. And then Karthik was talking about sort of initiatives to improve time to care, which helps improve capacity. But is there a bit of a tension perhaps in the investment of time and resource to capture all of the data, to give you the data that can be analysed, then to identify the improvement opportunities? And is it hard to get the balance right so that you're actually going to arrive at the improvement, but recognising the manual input to get you there?
Yeah, and that's such a good question. And so what we often find is when you're at that level of, I'm going to do this really manual breach analysis, and don't get me wrong, there are tools that allow us to automate some of that stuff. So, for us, it was a For today, it was very much, if you were starting from scratch, this is the kind of methodology one uses. So we have tools, we've built tools in organization which automate a lot of that by taking information from your EPR and analyzing it based on intelligence that what we create in terms of algorithms and so on and so forth. So that is completely achievable. There's, robotic process automation tasks that can be built as well to support some of this analysis. And we do all of those types of things. But again, they need to be specific to the organization. Having said that, if you are at that place where that feels a bit further away, because often we find when we talk about sort of technology and digital tools like that, people perhaps feel overwhelmed because they've never looked at the data in this way, or they've never, or there are sort of significant data quality challenges, and it feels too far to go straight into a technology solution, which is fair enough. In that scenario, when you are sort of not going to take up a technology solution for whatever reason, whether that's overwhelming or funding might be a challenge, a sample of these breaches is enough, because the themes will start to come through. The more you do it, the themes will, and a lot of the operational and clinical people who'll be on this call and indeed do this on a day-to-day basis will anecdotally know what causes the breaches. This type of stuff just helps you really hone in and give the evidence that you need for a business case, perhaps, or indeed for making the case for a certain type of intervention. So even if you did a sample-based analysis, that would get you important information. However, yes, absolutely, there are digital tools that can support that, and I'd be happy to talk to anybody in detail about that separately.
Thank you, Karthik, and then I better put back to Lucy for another question. Karthik.
Thanks, Sarah. I'll make it quick. And it's a great question again. I think the part of the question also touches on, so while the manual collection of data and analysis is probably done by the business intelligence and performance team, the collection of data by clinician on the front end will take time and will actually is contradictory to the point we discussed earlier around freeing up clinical time. So there is that piece of how we actually design or redesign the configure our EPR system that makes it much easier for clinicians to record the information much more easily and intuitively, rather than actually having multiple clicks and going into different pages and entering the information. So that part of piece of the jigsaw also need to be addressed, which is being done already by many trusts.
Thanks, Karthik. Lucy, do we have another question?
Thank you. Yeah, I'm conscious of time, but we've just had a couple of comments from Francis, who's been on the webinar. So thank you for those, Francis. So I'll just read them out and then may prompt a brief, quick response. So Francis just said, just to comment, the key challenge for many mental health trusts is having defined capacity and tracking this, and having clearly defined pathways, i.e. what is the treatment offer, how many sessions, and having an idea of broadly how many session patients need. And then followed that up with, there is also the issue in mental health of pathways spanning across organisations, and overcoming the challenge of interoperable systems to understand weights across pathways. So I don't know if there's, if anyone wants to respond to that comment.
Karthik, do you want to go first and then I'll come in?
Yeah, sure, Karina. That's a great question and comments, Francis. I think you're absolutely right. I think these are some of the practical challenges that we have in mental health. I mean, there are a couple of options that we currently have, that's going to help, hopefully help, to address those issues. One of that is NHS England is actually trying to collect the data set from various sources and trying to stitch it themselves. But there's also a federated data platform currently that the project is actually up and running, which is actually collecting data from disparate sources and different EPR systems into a central repository, that can actually provide that can actually bridge that gap, where data is lying in different systems and connecting the pathways and stitching the waiting list together. So I mean, hopefully that should actually that is actually a solution that I can think of.
Thanks, Karthik. Just briefly from me. Yes, the federated data system will be able to sort of do some analysis when you're feeding it the right data sets. when you're capturing the right data sets, when you're getting the right data quality, but most importantly, some of you will be also pulling together the sort of weekly mental health data list as well. But what you'll find is, and if you're interested, please do get in touch with our team. We're very happy to show you so for the last 8 months only, NHS England has started publishing the data that mental health organisations are submitting to NHS England around waiting times on both sort of children and young people services and indeed adult services. And you'll be surprised when we put that in front of mental health trust leaders that I don't recognise this. So what many organisations are submitting to NHS England is very different to what they recognise internally. Now the question is, why is that? Is that a data quality issue? Is it just a reporting challenge? Are you measuring the right things according to NHS England's requirement as well? So it isn't as complex as it all sounds, and quite frankly, this is kind of where the kind of work that we lead on in many organisations, and indeed in Karthik's old organisations at Barnet. This is the kind of work we did, which is about understanding: are you capturing the right data points? Are you then measuring the right data points? But as Francis, you've rightly picked up, it's not as simple as capturing and sort of recording and measuring and then reporting on the right data points. Have you even mapped out your clinical pathway correctly? So when we started the project around building a PTL at Barnet, the first step for us was nothing to do with the data. It was to map out the clinical pathways. So you're absolutely right. That sort of is a precursor to everything. But individual organizations must get at the hang of their own data elements before the FDP can be useful. So perhaps the FDP will absolutely support and sort of the aggregated element, but if what you're submitting is challenged already, it won't get you there. So individual organizations need to kind of take it by the reins and recognize the sort of issues that they're facing in their data. And as I say, it's publicly published data by NHS England, which we're very happy to share, which we've created into some dashboards for at organisation and ICS level, which we'd be happy to send to anybody who's interested.
Karina, thank you. Somewhat inevitably, we've run out of time. This is always the case. There's so much of interest and much to explore and discuss, but time always seems to be against us. So thank you hugely to both of you, Karina and Karthik, for taking us through such an interesting and important area, actually. Really good to hear both the theory side, but also the practical application and the work you've been doing, Karthik, to use some of these tools and put them into real life within the organisation. So thank you to everyone for attending. As I said at the beginning, the recording will be made available and also the slides. And if there were questions posted that haven't been answered, then they will be picked up and responded to separately. So you will get answers to the questions you posed. And there've been a couple of invitations there from Karina. If there's stuff you're interested in, express an interest, let the team there at Acumentice know, and information can be shared, particularly some of those tools and some of the data that you were describing. So thank you. Excellent webinar, really, and an excellent series, actually. And for those who've been able to attend all three, you've probably got quite a rich bag of useful information and tools to start exploring and thinking about in your own organisations. So thank you, and see you again. Thanks very much, Karina and Karthik.
Thanks, everyone.
Bye now.
Thank you, Sarah.
Thanks. Bye-bye.